Hi, it's Dr. Centeno. Thanks for joining us today. Let me share my screen so we can start with the presentation. We're going to be talking about the sternocleidomastoid today and how that really impacts neck pain, craniocervical instability, how it's associated with C1, C2, balance, all sorts of good stuff here. So let me get to this here. Okay, so what is the sternocleidomastoid or SCM, and why is it a big deal for neck pain and CCI patients? Now, I'm going to be talking about this today, but obviously you can ask questions about anything. If you want to ask any questions, obviously just put those in the comments. And obviously you can ask about this, but you can also ask about whatever is on your mind. So let me get the pen going here. So again, what is the SCM or sternocleidomastoid? Why is it a big deal for neck pain and CCI patients? So before we begin, this coming Friday, I'll be talking about our new degenerative disc disease study. And that's a new study that'll be free of charge for those that qualify. It'll be lumbar or low back. And it's going to be patients with low back pain due to degenerative disc disease that would ordinarily be considered a fusion candidate, but instead they'll be randomized to either get a platelet-based DDD treatment or a sham treatment. So I'll be talking more about this on Friday. I think there were some crossed wires with regard to which one we were talking about today. So I did want to mention this today, that we do have this study. I'll be talking more about it this coming Friday on all these same channels at the same time of day. So just to kind of let everybody know. So the sternocleidomastoid muscle, or SCM, is located in the front of the neck, and it kind of goes from the mastoid process up here in the skull down to this area in the front of the chest. And that's the big muscle you can feel right on the side here. In fact, it's the biggest muscle that you can feel in the front of your neck. And the SCM has two heads. And if you look at the term sternocleidomastoid, sterno comes from the head that goes on to the sternum. Cleido comes from the head that goes and attaches to the clavicle. And the mastoid is on the skull side. So sternocleidomastoid, so the M here, mastoid, is the mastoid process in the skull, which is right up here. And the SCM's function is to turn and flex the head. It also laterally bends the head. So it can help you bring your head forward. It's a big prime mover in turning the head. And you can also, if you just contract one of them, you can bend your head laterally as well. So it's got a lot of different functions, and it's one of the prime movers of the head and the skull. Now, the muscle is supplied by the 11th cranial nerve, and that's what you see a picture of here. And that's also called the accessory nerve. Now, kind of note how this nerve comes out at the base of the skull here. So if you've got instability of the skull on C1, then that could possibly irritate this nerve. Also realize that if this nerve gets irritated, their sternocleidomastoid muscle can get tight. And this nerve also supplies the upper trapezius, so that muscle can get tight. And that's not uncommon to see, for instance, patients with craniocervical instability who have accessory nerve irritation leading to tightness in the upper trap and SCM. And there are times where the goal is just to treat the instability, other times where the accessory nerve is directly treated. Now, trigger points in the SCM. What is a trigger point? A trigger point is when the muscle gets knots in it, if you will, or areas of the muscle that don't contract and feel like a knot. And those trigger points can refer pain to lots of different areas. Now, I have drawn up here where those referral areas are, but you can see kind of on top of the eye is the most common one, and that's in this kind of deeper red cover, also the back of the head. And then it's possible in the front of the forehead area here and the top of the head and underneath the chin, kind of in the anterior neck, including the cheek, and sometimes into this temporalis area of the skull. So these are spots, and you can find these by just feeling in your SCM and see if you can find a knot. And when you press on the knot, does it go to any of these places? Now, sometimes getting rid of something like this is merely a function of having that trigger point worked out through manual massage, or having that trigger point injected or dry needled. Now, transverse cervical nerve. There's lots of different nerves, a lot going on here, but I tried to make sure that I highlighted the transverse cervical nerve. So there is a nerve that comes out from behind the SCM. So on the image on the left here, we're looking from behind the sternocleidomastoid, and the person's looking away from us. You can see the sternocleidomastoid is here, and it's the one that's all highlighted. And you can see these nerves coming out from behind the sternocleidomastoid, and those represent the transverse cervical nerves. And on the image on the right side of the screen, you can see the same thing happening, but now just more from the side. Now, note where these nerves go. One goes to the front of the neck area, and one goes sort of to the side of the head, and the other one goes to the back of the head. The one that goes to the back of the head is actually the lesser occipital nerve, which is very commonly irritated at the back part of the sternocleidomastoid here, and that can cause pain in the back of the head. Again, lesser occipital nerve coming off of these transverse cervical nerves. And then you can see that the middle branch here is coming up to the side of the head, kind of where those trigger points go, and the other one's to the front of the neck, kind of where those trigger points go. So if these transverse cervical nerves are irritated due to tightness in the sternocleidomastoid, that can be treated with hydrodissection of this nerve underneath the tight sternocleidomastoid. Now, also realize that the SCM and balance are pretty key. And this is kind of a little bit of a sad story. Way back in the 60s and 50s, NASA was concerned about the idea that if you launched a human in a rocket and there was all these tremendous acceleration forces and the sternocleidomastoid muscles got injured, what would that do to the astronaut? So in primates, they cut these muscles, and what they noticed was that the primates were banging into walls, meaning they didn't have normal balance. So we know that the sternocleidomastoid is involved in balance problems. Now, lots of different parts of the neck are, right? We know the upper neck is involved. Now we know the sternocleidomastoid is involved. Balance also obviously comes from the inner ear and from the eyes. But on the neck side, realize the sternocleidomastoid does play a role. So in conclusion, the SCM is a critical muscle of the neck. It can become painful and get trigger points and then refer pain to different spots. It's also heavily linked into the C1-C2 facet joint. So a very important concept there is that the C1-C2 facet joint is where 50% of your rotation comes from. And this sternocleidomastoid is a primary rotator. So we frequently see people with C1-C2 facet joint issues who then have sternocleidomastoid issues as well. And it has nerves called the transverse cervical nerve that exit around it that can become irritated and shoot pain to lots of different places, including the lesser occipital nerve to the back of the head, and that this sternocleidomastoid is heavily involved in balance. So I'll stop sharing here, and we will start to take some questions. So let me go ahead and take some questions. Centeno Schultz, submitted by Harry Winston. Can chronic torticollis in childhood cause SCM problems in adulthood? Sure. Yeah, I think there could be a relationship there. Ricardo, greetings. Submitted advanced by Linda Kellum. I was diagnosed with SCM, not sure what was wrong with SCM, but SCM, but told there was no treatment by the doctor who made the diagnosis. Is there a type of doctor I should see for treatment? Yeah, Linda, you've got to see someone who specializes in this kind of stuff. So that would be for this particular muscle, as it might link to the upper cervical spine, that would be Centeno Schultz. If there's a few other sites around the country or one in the UK that might understand what's going on here. But yeah, 99.9% of the doctors you would see wouldn't have any sense of what was going on with the SCM. Probably even better to see a physical therapist with who has a high level of musculoskeletal knowledge, and that physical therapist might be much more experienced in treating or dealing with the SCM. Hi, Dr. C. Have you ever done a full headache workup on a patient with rebound intracranial hypertension? Well, Robin, the reason for doing a headache workup would be that the patient doesn't have any intracranial hypertension, meaning that there's no way to get to a diagnosis of intracranial hypertension and confirm that diagnosis. It's really just a diagnosis of exclusion. So there's no way to get to that diagnosis without floating catheters up into this area to measure the pressure in that area. So for instance, just high opening pressure on a lumbar puncture won't get to that diagnosis. So the reason to do a full headache workup, and what we mean there is, I think, a diagnostic block workup, would be to numb the structures we think that are causing head pain and try to see if we can hone in on which structures are causing the head pain. And if we found something, a structure in the neck that's causing head pain, by definition, that person wouldn't have intracranial hypertension causing their head pain. Robin, my SCMs feel thicker, thinner upon palpation. My traps are locked so bad. PPP was homered in the past. Yeah, Robin, it sounds like definitely need to determine next steps for treatment there. Vertical instability versus horizontal instability. Lately, we hear a lot the PSA would be more helpful for horizontal and less for cranial settling. What is your opinion? Yeah, Manuela, I mean, I don't know that that there's a way that we can determine if vertical instability is causing your symptoms. The only way to diagnose vertical instability would be that we do an invasive traction test. So that means put some screws into the skull and pull up and see if that person has laxity in the vertical direction. Outside of that, there's really not a way to get to that diagnosis other than to notice that the skull is lower than it is in most people. But getting from that to trying to figure out if you've got symptoms caused by that can't be done without either that invasive traction test, and then it's a little bit of a guess because there are other things that are being offloaded there that could also cause, for instance, headache. And really then the only way to try to see if this is causing your symptoms would be to try to do a fusion and raise the head, which is one of the reasons why I think we hear about things like releasing a tethered spinal cord, is because if you raise the head, that's going to cause some additional tethering type pressure. As far as whether or not PICL helps less or in vertical instability patients, I haven't noticed that yet, but at the same time, it's possible. But the problem is vertical instability causing symptoms, we can't get there without some very other invasive things being done. So that's why it's a little bit of a confusing concept and one that isn't black or white at all. It's kind of various shades of gray. Daniel, I'm still holding out this in alignment 10 weeks out from the first and single adjustment, but I still have a lot of symptoms like heavy head feeling and really stiff muscles. So if you are still feeling better after a single adjustment, I would definitely go back to that upper cervical chiropractic provider and see what their recommendation is. It's possible then that you don't really have instability, but have other things injured in the upper neck that are causing symptoms that may need to be treated. But really your first line of defense would be going back to that same provider. IMAS, who should I go to manage my SCM? So again, IMAS, this isn't going to a type of doctor in particular. You're going to have to see someone that understands these types of neck issues, and those doctors are few and far between. Donovan, is a radiologist qualified to inject cervical and thoracic discs with stem cells and his CT guidance? What questions can I ask to see if he knows what he's talking about? Doesn't matter if the cells are taken from fat. Let's see, Donovan, all sorts of things to unpack here. So the first question would be, do you need your discs injected? I wouldn't trust a radiologist to understand if you needed your discs injected, or at least 99.9% of the time. I think I know one radiologist around the country who I'd probably trust with that idea, but that's about it. Because that's not their area of expertise. They read films, they don't really examine patients. And that would take a good hands-on exam, a good history. We'd probably take a good 40 to 60 minutes just to figure out one-on-one whether or not your discs needed to be injected. Meaning that you don't inject discs in the neck and thoracic spine until you're absolutely convinced that injecting those discs will likely be a net positive. And that all depends on the type of disc, whether or not that disc is causing pain, whether or not there's instability at that level, what else might be causing pain, the facet joints at that level, the nerves at that level, et cetera, et cetera. And then as far as injecting them with CT guidance, that's absolutely overkill and ridiculous. You don't need CT guidance to inject cervical and thoracic discs. In fact, that's just exposing the patient to far too much radiation. What I mean by exposing the patient to far too much radiation is the average fluoro time, let's say on a cervical disc injection, would be about 1/100th or 1% of the amount of radiation in using a CT scan to do the same thing. So there's no reason to expose the patient to 100 times more radiation because you don't know how to do it under fluoroscopy or don't have the confidence to do it under fluoroscopy. Fluoroscopy is the standard of care here with far less radiation exposure. So there's just no reason to expose the patient to that kind of stuff or that kind of radiation exposure. What questions can you ask to see if he knows what he's talking about? That's a little bit more difficult, but I think I've got blogs on that topic. You may want to go to the regenx.com blog and type in intradiscal injection or disc injection. There's probably 5 or 6 things I've written about that through the years. And then as far as cells taken from fat, there's really no such thing in the United States at this point. You can do a fat graft, which will have some stem cells locked in the collagen. That's called microfragmented fat or MFAT, but it's not a stem cell procedure. It's a fat graft. Now, there really wouldn't be a reason to do a fat graft in a disc at all. So that really wouldn't be standard of care. What we have research on, and we know likely works, would be the use of either bone marrow concentrate or platelet-rich plasma. So if he's telling you that you need fat in your disc, that maybe answers your prior question that he doesn't really know what he's talking about, meaning that we can't inject fat stem cells in the United States under any circumstance. The best we can do is a fat graft, or what's called microfragmented fat or MFAT. So I know that's a long answer. We unpacked a lot of stuff there. But since this guy's talking about using a CT scan and injecting your disc with fat, I'd probably run and find another provider. Rachel, I have CCI. I'm quite debilitated. I have really good balance. Is it related to SCM problems? No, Rachel, it doesn't mean that if you have an SCM problem, you have to have a balance problem. There's just a subset of people with SCM problems that have balance issues. Mark, do the interspinous and supraspinous ligaments lumbar spine help stabilize the spine? They do. So yes, they are stabilizers of the spine in flexion, in addition to other ligaments like the iliolumbar ligament at L5. Kristen, is it bad to work on the SCM or thoracic outlet while in the middle of PICL or with instability? My SCMs are extremely tight and have symptoms of TOS. Worried to work release too much of these things, trying to help me with instability. Yeah, I wouldn't do those things right in the middle of treatment without approval from your doctor. The problem with many CCI patients is that they need the tightness in these muscles to stabilize their head and their neck. And when you get someone to try to take away that tightness, for instance, a common one will be finding someone to inject Botox into the sternocleidomastoids. Many CCI patients crash and burn because they need that tightness. Now, once we get stability up here and strengthening occurs, then those other things may need to be treated, or they can be treated with a PICL in such a way that you're not reducing the spasm, but you're trying to treat the bad effects of the spasm. IMS. I did 2 PICL, but my left SCM is still causing spasms and not letting my spine to be stable. Yeah, so then the question would be, do you need to have the SCM itself treated? For instance, for tendinopathy, meaning the SCM can have the tendons which get problems, and or the nerve going to the SCM, which is the accessory nerve, as we talked about. Those are the kind of things that you may want to think about as a next step in treatment. Kristen, is facet damage vertical instability? No, not those two things really don't overlap directly. So what I meant, I think, by that comment, Kristen, before was that, let's say, just for argument's sake, we do an invasive traction test. So we put a screw here, 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 here in a halo, and then the head is pulled up. Now, if we don't see any movement on an X-ray or a fluoroscopy unit, other than what we would expect when we pull the head up, meaning a little bit and the spine straightens, but the patient's symptoms go away, we have two things that could be at play there. There might be some effect of vertical, or there might be some effect of the head being, the skull being too far down or settling, cranial settling, in which case that might be what's causing the symptoms. But it's also possible that the symptoms were coming from the upper neck facet joints, which none of the surgeons understand or rule out at this point, not that I have seen. And we're just taking pressure off those joints so they feel a lot better. So the comment before was to make sure that everyone understands that when you do an invasive traction test and let's say your headaches get better, that might indicate that you have issues related to cranial settling, or sometimes that's done for Chiari type issues, or it might just indicate that the 0-1 facet joint is pissed off and you took pressure off of it. So just be really careful with that stuff, because there's a lot of different interpretations of that particular test. Adina, do you think high translational BDI makes high dynamic BDI invasive traction rate also likely? Not 100% sure of that question because of the way it's worded. But listen, translational BDI is the same thing as a grab oaks that increases. It just means that we're seeing motion between those structures in flexion and extension, and isn't necessarily related to vertical instability, because you can have motion between the skull C1 and C2 without any type of vertical instability. And in which case, we're just talking about motion in a front-back plane rather than a side-to-side plane. So now, but let's say we go ahead and we yank on the head. Now we're doing a different test, right? We're doing a test where we are trying to see if the skull dramatically separates from, let's say, C1 or C2. In which case, I would buy that there's vertical instability. Now, the next question would be, if you have vertical instability in this direction only and without settling, then you should try to inject those ligaments that have to do with vertical instability. If you've got settling plus vertical instability, and you believe that's causing symptoms, then it may be reasonable to get the vertical instability fixed with fusion, but realizing that's the only way you're going to be able to determine whether or not that combination actually is causing your symptoms. Meaning there's no other test I can do that will definitively diagnose that vertical instability is causing your symptoms. It's all just guesswork with a little bit of educated guessing in there. And I know that's something hard for patients to hear, because they don't really want to hear that their diagnosis is not based on something that is rock solid. They want to hear that it is rock solid, right? That there is absolutely no way there's something else causing their symptoms. It has to be this. But regrettably, we're not living in that world when it comes to CCI or vertical instability. Jay, regarding the SCM, would instability be more affected by CCI or by overuse in the shoulder? I've noticed I've issues SCM on days I work longer at my desk than I do yard housework. I'm not quite 100% sure of the question. Would instability be more affected by CCI or overuse in the shoulder? Listen, we see patients who have instability in their shoulder joints that definitely overlap with their craniocervical instability. So we'll often treat the shoulder joint instability when we're treating the craniocervical instability. And then as far as the SCMs being more involved, when you're sitting, that makes sense, right? Because when we're sitting, we tend to do this. And by doing that, we're shortening the SCMs. So that, I think, would be common in folks that have SCM issues. Now, if you were to sit with a good lumbar support, so something's behind your back, and you're sitting up straight, and your head is not forward, then I suspect that your SCMs won't be aggravated as much. So you may want to try that. Daniel, do you know if correcting the jaw and improving TMJ will help CCI? Not usually, Daniel. It normally goes the other way, that CCI ends up causing issues in the jaw due to the anterior stabilization system getting overworked. So we generally don't see it go the other way. I've seen very few patients whose CCI symptoms go away when treating their jaw, but we do see CCI patients who need their jaw treated because they have jaw issues related to the CCI. CN, 2 nerve injuries in the face. Does this need to be addressed for PICL? Really beforing me. I would need to know more about what nerve injuries we're talking about. Trigeminal neuralgia, other nerve issues in the face. How specifically was that diagnosed? How certain are we about that diagnosis, et cetera, et cetera? My left trap muscle is causing a lot of pain. Yeah, so as we talked about, that could be that accessory nerve. So the accessory nerve, realize, goes both to the sternocleidomastoid and to the upper trap. So sternocleidomastoid, upper trap. So just realize that if the nerve is irritated where it's coming out, way deep in here at the base of the skull, that can lead to tightness there, and that nerve may need to be treated. Adina, facet misalignment implies CCI, AAI. Yeah, so there's 2 concepts here, Adina, and they overlap a little bit, but they're quite separate. One is that the facet joints are injured or damaged and not unstable, but causing pain. The other is the facet joints are unstable or misaligned, let's say at C1, C2, and that's causing pain, not only because of the instability, because the facet's getting damaged from the instability. But realize you can have painful facets without instability just because those facets got damaged, in which case the treatment is very different. Kristen, thanks, actually makes sense. You have sort of answered this, but is it possible my SCMs will become less tight if PCL and may treat on its own? Yeah, Kristen, that's usually the first way to try to treat tight SCMs, and we will frequently see that go away. If not, then we can treat the SCMs directly. Now, there are a few CCI patients where the SCMs are just on fire, and it's pretty clear that whatever has happened over the long run, those SCMs are taking on a life of their own, in which case we'll treat those out of the gate, but that's less common. I think PSA will work better if Regenerative has an AO chiro right after the procedure. Yeah, Yamas, we certainly encourage people to go to their NUCA or AO chiros right after the procedure. In fact, we've got folks here in Denver. One I can think of in particular, she's an AO chiro who's very, very good, who we refer directly to for those patients who dramatically benefit from AO, and she's been a lifesaver for many patients. So yes, we do that all the time. After AO, my left trap immediate release, what do you think damages? Again, that would argue that the issue is higher up in here where that nerve comes out. Remember that picture, and I'll put it up again just so that we can see what it is I'm talking about here. Okay, let me share my screen so we can put this back up so everyone knows what we're discussing. Okay, so remember when I talked about the accessory nerve, right? The accessory nerve comes out right here at the base of the skull. So if it gets irritated there, one of these goes to the SCM. So that's going to get tight. One of those goes to the upper trap, and that's going to get tight. And when you have AO treatment, which is aligning the skull on C1, C2, then that tightness is going to go away because the nerve's no longer irritated. So realize that that's sort of the connection here that we're talking about. Okay. Tell me, guys, did you see that? Oh, screen not shared. Sorry about that, guys. I'll do that again. That was my fault here. My bad. Okay, let's try that again. Let's share this. So getting back to where I was. So realize that this accessory nerve comes out at the base of the skull. So if there's instability of the skull on C1, then that's going to cause irritation in this nerve, which will cause tightness in the SCM and tightness in the upper trap. And obviously, if you get all of this aligned up here in the appropriate type of chiropractic care, then the SCM and the upper trap are not going to be as tight. So that was the general concept there. Okay. Trigeminal is BS. Once you get pressure off nerves, no pain remains. Yeah, I don't know if it's BS, but certainly we have a large segment of the population or a substantial chunk of CCI patients that have pain in the face. Sometimes that's related to trigeminal neuralgia, which usually resolves once you stabilize the craniocervical junction. Some of that's even related to just local pain in the TMJ temporalis, and it's been diagnosed or wrongly diagnosed as trigeminal neuralgia, or the patient's done a self-diagnosis of trigeminal neuralgia. When I did my first AO, my trigeminal pain went away slowly and surely. Yeah, that makes sense. We see that quite a bit. Lingual nerve injury from wisdom tooth removal. Now my bottom left molar, causing it to go numb and keep on biting my tongue on that side. I notice it affects one of my teeth on that side. Yeah, that certainly can be a real thing. Manuela, how do we determine if set joints are damaged or just misaligned? Manuela, that can be done with a combination of things, right? The first being a hands-on physical exam and or treating that joint to see if the symptoms get better, or performing a diagnostic numbing injection of that joint to see if the pain that you have goes away when the joint is numbed. and or combined with looking for instability at that joint on things like dynamic motion x-ray. So all of that put together can get to whether the facet joint is just damaged, causing issues, or unstable and causing issues, or both. CN, how do you add to that? The other nerve injury was from my nerve being exposed. It got compressed in an injury. It's my upper right molars, nerve that runs along got squished. Should I fix these too? See, I think what you're saying is you had a lingual nerve injury due to having a wisdom tooth removed. I don't think there's a way for me to help or folks that treat the neck to help that issue. I think the bigger question is the long-term pain in there due to that or something else that could be helped? Manuela, how long after PICL should try AO? Manuela, if someone walks into our clinic and they swear by AO helps them temporarily, we are generally setting them up with a local AO provider right after the PICL the next day so that they can get put back in place. So that's generally how we're doing. Now, if someone's never had any exposure to AO, we certainly don't want to start after the PICL, in which case that's not happening. How do actually know regenerative medicine help with tightening or aligning cranial sutures? No, Shanzai, I don't know of any at this point. Adina, can accessory nerve be tested with EMG? Yes and no. Realize that EMG is only going to find if the nerve has been substantially damaged. So EMG is highly specific, but poorly sensitive. And sensitivity in medicine means that there's lots of patients that have nerve problems with regard to this test that have a normal EMG, but clearly have nerve problems based on physical exam. Blocking that nerve makes their pain go away, but the EMG is totally normal. So realize that, if you had severe accessory nerve damage, an EMG would find it. But unless it was severe accessory nerve damage, the EMG is going to be totally negative. And we're going to be scratching our head saying, wonder what's going on here. How can regenerative medicine treat a fatty infiltration? Not sure I know what you mean. If you mean fatty infiltration of something like a multifidus muscle, then the goal is to try to provide regenerative medicine solutions, usually platelet poor plasma, that can help the muscle satellite cells do their thing while you try to get the muscles back online with physical therapy. Is massaging the SCM area a good idea? Yeah, Ravati, there's no problem with massaging the SCM. You just have to see if you can tolerate. We have some of our CCI patients that wouldn't be able to tolerate, most would. So if you can find those specific trigger points, just doing some pressure massage on those trigger points may help quite a bit. CN, is that playing a role in the neck being irritated? I'm stuck between fixing the neck first or the facial nerves first. One of my family members is saying the neck first. Yeah, I just don't know. Obviously, if the facial stuff seems to be coming from the neck first. If it seems to be aggravating the neck, then those other nerves first. But you also need to be conscious of the fact that if anyone's going to do something around in here, they're probably not going to protect your neck really well during that procedure. So that's the hard part for many CCI patients is getting other procedures before that involve the head or neck. You're going to be dealing with a team that's not used to stabilizing neck or caring about what position the neck is in, which can then lead to other issues and problems. We've certainly seen that. Okay, other questions I can answer. It looks like come to the last of the ones that are here. And I'm not sure if I'm saying your name right, Imas Lamas. I feel like if the SCM, left SCM releases, I'm going to be stable up here laterally. What should I do? Yeah, so then it seems like you may just need that accessory nerve directly treated. I would also obviously try to do some manual massage on the left SCM. If that doesn't work, then you may need that accessory nerve treated as well. You'd also want to see if there's still C1, C2 instability. because if there's not, then the focus is going to be that accessory nerve. If there still is, then we still have to get rid of the residual C1, C2 instability. If there are fascial tears, can PRP or stem cells heal that? How to assess if the transverse tendons or muscles are torn? Not sure what you mean by the transverse tendons, but yes, we use PRP or bone marrow concentrate to treat fascial tears all the time. Ilma, sorry about that. I didn't get that. Other questions I can answer today? AO makes me feel better. Does this mean I still have transverse or alar damage? Yeah, Ilmas, the best thing to do then would be to get a repeat study. So if you had instability, for instance, on C1, C2 overhang on DMX, we'd repeat the DMX to see if that's gone away and back into the normal limits. Shanze, sorry, intertransverse tendons and muscles. There's a transverse ligament. Do you mean the intertransverse tendons and muscles that go up the side of the cervical and lumbar spine between the transverse processes? Let me know if so. Cian, are the ligaments as strong as they were before, after PICL? I don't think anyone knows that for sure. Best I can tell you is that we have seen DMX overhangs, for example, that can easily be measured, go back to zero or close to zero. Now, whether or not that person, if they got into a car crash, would have the same resistance to additional CCJ injury as someone who was never had this issue, I don't know. And I think that one's would be a hard one to determine. Kristen, 7 weeks out from PICL, I have to be upright most of the day because of my kids, but I have a hard time opening my shoulders because rolled in trying to hold my head up. Can you still heal through a forward head posture? Do you see the influence healing? Yeah, so Kristen, that's a hard one because I think as we talked about, when your head is forward like this, you're putting a lot more pressure on those upper cervical ligaments. You may want to see a very specific type of physical therapy provider, someone who is on the IPA network. Let's see if I can get to, I'll share that here. So if you go to Google and you just type in IPA physical therapy, the Institute of Physical Art will come up, and here they have a find a provider deal. So I would go ahead and consider seeing these guys or one of their trained providers who might be able to help you with some manual work to try to open up the chest so that it's easier to tolerate, because once you get fixed in this position, it's very hard to do anything else. But once you open up the chest and the anterior neck, you can start to offload that area. So I would see one of these guys. Can we go back to normal, or do we have to be cautious? I think you mean after PICL. A lot of that would depend on where you start. Meaning, do we have PICL patients who went back to what they were doing before? Absolutely. We've had patients go back to running. I've got one patient that went back to jujitsu. Now, they both started at a pretty high level, however. So somebody who has been in bed because of their CCI is unlikely to get back to that position. So a lot would depend on where you started. But it's the same thing with surgery as well, meaning that I don't know of any surgical patient that's gotten back to full activities ever that I have ever seen. You're always going to have significant limitations, especially if we fuse 1-2, right? If you fuse 1-2, you lose 50%, 50% of your rotation. So, even driving a car is different. If you lose 50% of your rotation, you have to do that versus look over your shoulder kind of thing. And obviously, that's just the beginning of getting a C1, C2 fusion. Ravati, have you seen burping while doing chin tucks, neck traction in patients? Haven't seen that as much as a symptom, so I don't know that I've got a good sense of what's going on there. Shanze, yes, those that go to the side transverse process. Separately, have you ever seen posterior injections help with mild transverse ligament laxity between C1 and C2? Shanze, we routinely inject that ligament. Above that, that's called the Atlanto-occipital ligament. Between C1 and C2, it's called intertransverse ligament. We do that all the time, and yes, it does seem to help. Ilmas, New Jersey has DMX. Should I do another one and send it to Regenerative? Yeah, as long as it was a good study. You need to send it to your doctor who did your procedure so he can compare before and after to see if you have normal overhang at this point. Levon, if MRI shows increased amount of CSF in the brain around frontal parietal lobe, can it be due to drainage issue due to CCI? It's possible that it could be due to that. It's possible that it could be due to something else entirely different than that. So just realize that that's in the differential diagnosis of things that could be, but doesn't cinch the diagnosis at all of issues with drainage due to CCI. Ilmas, should I go to a physical therapist also? You know, Ilmas, that's something you got to ask your doctor specifically. Happy to help, Kristen. Brendan, do people typically have trouble with stiffness and not being able to rotate their heads as much after posterior treatments at Regenerative? I imagine there's some definite tightness initially, but what about several months out? For PICL, what can you expect for reduced range of motion stiffness? Brendan, I think you told me you did not go to Regenerative to get your posterior treatments. I think I went back and forth with you on this, so I don't want to get into your personal treatment history. I know I had some significant concerns that I expressed in the emails, so best to take that one offline. Ilmas, my neck bones are still adjusting. I think I should wait. Okay, sounds good. Sion, thank you. It sounds positive. Muscle dysfunction usually from ligaments or nerve dysfunction. Am I right? Yes, commonly that's the case, or it also can be due to muscle imbalance too. Donovan, why are you so concerned when it comes to injecting discs when it could help or at least stop degeneration getting worse? Isn't the complication rate very low? Is it because 10% of people get discitis and you don't want that in your name? Donovan, listen, there's a chance for discitis. It's about 1 in 200. When that happens, that's a huge mess. I'm not talking about just take some oral antibiotics. We're talking about getting a catheter inserted that goes into the area of your heart that then will have IV antibiotics injected into it for 6 weeks, usually by a home health nurse that comes to your house once a day or twice a day or whatever the regimen is. And then you get, on top of that, the privilege usually of having disc surgery to wash out the disc. So discitis is an absolute mess. And there's about a 1 in 200 chance that that'll happen if we inject the disc. We also see that injecting the disc about 80% of the times isn't needed at all, so that you can get the same results or better by staying out of the disc as injecting the disc. So in that case, you know, I always have that conversation with my patients. Here's the risk of discitis. Here's what a mess that will be if that happens. And here are the risks and benefits of injecting that disc. Now let's get into the benefits. Do we know that will stop degeneration from getting worse? We don't. There's no data at this juncture that shows that, or at least no convincing data that shows that with any treatment of the disc to date. So we don't have that data, and we certainly don't have it for injecting fat into the disc. So I'm conservative about injecting the disc because discitis is a total mess. Number one. Number two, we don't have data that injecting anything into a disc will reduce disc degeneration. And number three is we can usually get rid of disc pain, or not disc pain, but neck or upper back pain without injecting the disc at all. Now, having said that, do I still inject discs? Sure. Probably not a week or two that goes by, I'm not injecting someone's disc for something. But I don't do it out of the gate without just having that discussion with the patient. Meaning, if you get discitis, it's going to be an unadulterated mess. Ilmas, my right side was a whole lot better. Great. After 2 PCIL, thanks. Yeah, it's 1 in 200, Donovan. That's the quote. Now, some places, in some instances, it may be higher, but 1 in 200 is approximately the rate in which it happens. And like I said, it's an unadulterated mess, meaning that disc will never be the same. That patient will never be the same, meaning there is no such thing as recovering from discitis and the disc being normal. It means that the end plates get eaten up and destroyed. It means that disc will auto-fuse at some point. It is an absolute unadulterated mess. Shanze, does reducing scar tissue make any instability worse? I don't know what you mean by that. You'd have to ask that one again, Shanze. The SCM feels like it's connected with upper skull muscles, above ear muscles also. Feel a lot of pressure beneath my left ear. Yeah, so that can be because of irritation in front of the sternocleidomastoid. And that nerve there that comes off those transverse cervical nerves is called the temporoauricular nerve. And that can go and cause pain in the ear. So that's a thing. Cian, ozone therapy, what is that used for? Ozone therapy in the US isn't used for much. In Europe, where there are ozone generators that you can buy for clinical use, you can't buy those in the US, although some people try to import them. But in Europe, it's been used primarily, at least the research is, it's been used primarily for herniated discs and where the ozone is injected epidural. Donovan, how can you avert the risk of discitis if you decide to go in? There's no way to get rid of the risk for discitis. Now, Greg Lutz and our team, Greg Lutz out of the Hospital for Special Surgery and our team here in Colorado, did a joint experiment. I'm not sure if it's been published yet. Let's see if it has been. I don't know if it's been published yet. Where we looked at that issue of mitigating discitis. Let's see if it got published. Not yet. Anyway, I can tell you what it says. It's been submitted for publication. What it basically says that if you use 20x, so 20 times over baseline leukocyte-rich PRP, which needs to be made in the lab. It can't be made in a little bedside centrifuge that most physicians use. And a low dose of gentamicin, which is a type of antibiotic that seems to, at least in the lab, that seems to most effectively kill the type of bacteria called P. acnes that usually causes discitis. Now, that doesn't mean that this works clinically. It just means that in the lab, it seems to work the best, that combination. So 20 times over baseline leukocyte-rich or red PRP with a low dose of gentamicin, at least in the lab, seems to reduce or kill the bacteria that causes discitis. So that's the protocol we've been using now for the last 2 years or so since those experiments were done. And so far, knock on wood, so good. But the problem is you would need 1,000 cases really to see if the prevalence of discitis has changed. So it's going to be a while before anyone knows whether or not that's working. But so far, based on research between our team and Greg Lutz of Hospital for Special Surgery, that seems to work in the lab. Shanze, I was asking that to Yamas. Oh, okay, gotcha. Do your patients ever get discitis? I've had one discitis patient in my, I believe, trying to make sure that that's a true statement. I think that's a true statement. One discitis patient of mine who was probably about 10 years ago, 8 years ago, something like that. He was a bone marrow concentrated injection into his lumbar disc. And again, an unmitigated mess. As far as in our practice is concerned, we've probably had 3 or 4 in total over the last 15 years or so. So again, the rate's about 1 in 200, and that seems to be about right. And like I said, it's an unmitigated disaster every single time. Mark, with annular disc tears, would the disc be painful anytime you're sitting, or could the tears only be painful in unstable spine moves, for instance, when the facet joints get stuck, jam, and extension? Trying to determine pain is from annular tears or not. Yeah, Mark, so for painful annular tears, there's kind of a triad of things to look for. The first would be that there's an MRI that shows a bright, high-intensity zone in the back of the disc. So if we look at what a high-intensity zone looks like, let's see if we can find some good pictures of a high-intensity zone. Actually, this is from my blog, but I'm not sure if you can see it, but that white little spot in the back of the disc is what's called a high-intensity zone. So that's one thing. Second is the patient's generally over age 55, or I'm sorry, under age 55. So younger, bright spot in the back of the disc. And then the third thing that we need to think about is the patient can usually quantify sitting in terms of minutes. What I mean by that, if you talk to these patients and you say, how long can you sit? They won't just say, I can sit for a couple hours. They'll say, oh, I can only sit for 5 minutes or 10 minutes before I have to get up because my back hurts so much. These are generally the patients you see wandering the aisles in an airplane because they can't sit. So those are the 3 things you generally look for in looking for what we call discogenic pain, or pain coming from the disc. ILMAS, the SCM goes under the chin all the way to the chest. It feels like a tight rope. Yep, that makes sense. Sian, thanks, Doctor, for your only doctor that takes this stuff serious. Why is it like alien language to the majority of people? Yes, Sian, I would agree with you. And I think that's the hard part, and the challenge that we all face is what we're talking about takes a long time to learn. For instance, we have a fellowship program. So if a doctor came from Harvard and said, tomorrow I want to work in your clinic, we would turn them down. Same thing for Yale, Oxford, Cambridge. They're not qualified to work in our clinic until they do a year fellowship with us so that we can teach them this topic of medicine, because I don't care where they come from, they don't have this knowledge out of the box to know which end is up in talking about these issues that we're taking for granted here, right? We're talking about this nerve, that structure. Should I inject the disc? Should I not inject the disc? When should I inject the disc? What does C1, C2 do? What is that pain like? Diagnostic blocks at 0-1. We take for granted that these topics are common because we're talking about them every week. But you're right. You'll go into you go into Harvard tomorrow and see what seems to be a very qualified guy, but he won't have a clue what we're talking about here, despite the fact that the research would support what we're talking about here. Ilmas, do you think reducing 40 pounds of weight will cause CCI healing or make less pressure on the spine, and will it help me heal faster? Ilmas, there's no doubt that losing weight has a positive effect, not only from a mechanical standpoint, but also from the standpoint of a reduction of inflammatory chemicals in the bloodstream. Yes, I would. If you can do it, I would encourage you to lose the weight. It may not be transformative when it comes to your neck, but it's sure ain't going to hurt. So I think it's something that you should really consider doing. And I would encourage all patients to do, because it will make a difference in lots of separate ways. Okay, guys, well, we're coming to the end of the hour. Yes, the SCM turns the head, and that's going to take C1 with it for sure. Okay, guys, we're coming to the end of the hour. I want to thank you for staying with us through the end of the hour. Again, this Friday, I'll be back at 1 p.m. Mountain, which is 3 p.m. Eastern and 12 noon Pacific time, to talk about our new degenerative disc disease study in the lumbar spine. Lumbar spine DDD study is a randomized controlled trial that I talked about earlier. So if you're interested, or you think you have a loved one that might be interested in that study, which is free of charge care for someone who otherwise might need a low back fusion, then please join us on Friday and we'll talk some more about that specifically. And obviously you can ask questions about anything on Friday. It doesn't have to be that. So thanks so much for watching, guys. Have a great day and a wonderful week. Thank you.